So today we're going to be talking about tuberculosis and tuberculosis and HIV interactions. Because of the special relationship that tuberculosis has with HIV, we have to mention that, at least for the sake of comparisons. So tuberculosis has been with us from the beginning of times. It was estimated that in 1800s about a third of the world population died of tuberculosis. Do you guys know what's the date that tuberculosis was officially discovered and who discovered it? It was March 24th in 1882, and until today we celebrate March 24th as the International Tuberculosis Day. Not that it's much to celebrate, but it's an opportunity for education and spreading the good news, how it can be treated and prevented. It was Robert Koch who discovered the bacilli. Until about 1940s, the only thing that we had against the treatment of tuberculosis was isolation and sunlight. The first medication showed up in 1950s. It was isoniazid. In 1970s, was followed by rifampin, and in the early 80s by pyrazinamide and ethambutol. So as you can see, the medications, even that are first line for treatment and therapy, are about 50 or more years old at this time. So objectives for my talk today, I want to briefly describe the epidemiology, explain the difference between latent and active TB, how each of them are diagnosed, what are the signs and symptoms, how the disease develops, what is the different treatment options for latent TB and active TB, what is the relationship between TB and HIV, and what are the treatment options in co-infected patients and how do they differ. So as you know, as I mentioned, tuberculosis has been with us from the beginning of times. You will see that the total number of cases for TB has decreased, but it's worrisome, the rate of decrease, as you can see, has slowed down. So the absolute number of cases has decreased, yet the rate of decrease, we are plateauing off and decreasing. And you will see that the data for tuberculosis is going to lag about 2 or 3 years, because, why is that? Any guesses? Treatment of TB takes sometimes year, 2 years, 3 years. So for us to have a complete data sometimes for cases from 2001, sometimes we'll be closing them and they will become recorded as cases in 2013 or 2014. So it's only one of the diseases where you see the 2-3-year-old newest data on TB, if you will. So what contributes to the increase in TB morbidity? HIV? What else? Absolutely, increased immigration from areas of high prevalence. What are congregate settings? Prisons, dorms, military, shelters, military congregate settings, and of course deterioration of the healthcare infrastructure. What do I mean by that? One example is until a few years ago, we were able to do directly observed therapy for patients with latent TB and HIV, co-infected patients. At this point, we don't have resources. So our HIV positive patients get 9 months script for their INH, and they take it on their own. So you can see the completion rate of the latent TB is much slower, much lesser. Thankfully, we still have enough resources to do directly observed therapy for active cases of TB. So what is the incidence of TB? As you can see, worldwide. And in United States, this is the table from 1998. As you can see, in 2012, we are a state of Florida still leading. That's not something we want to be leading in, but we are as well. So who gets TB? This is not a disease of the elderly, the frail, or the very young. The majority of the cases of TB happens in patients who at the prime of their age. So as you can see, the ages between 24 and 45 comprises majority of the patients which come down with tuberculosis. The cases reported by origin and race ethnicity, as you can see, Caucasians contribute about 35%, African American 37%, Latino population about 19%. Out of the foreign-born individuals, majority, about 45 cases, are in our Asian population, followed by our Latino population, and about 14% in our African American population. So this is the latest data for United States. As you can see, something happened about 2001 and 2002. Up to then, majority of cases of TB were our homegrown TB. Since then, majority of our cases are coming from and are diagnosed in our foreign-born individuals. What are the countries of birth for foreign-born persons? As you can see, majority come from Mexico, Philippines, followed by India, Vietnam, China, Guatemala, Haiti, and about 40% is a potpourri of patients from all the different countries. Our two neighbors, the relative neighbors of ours, we don't have many cases, what you can think of. One of them is Canada, right? I haven't had any patients from there. But one country close to us, which we have a lot of immigrants, that I had maybe 4 or 5 cases in the past 10 years that I have been doing tuberculosis. Anybody can think of it, what it is? Cuba. They have a very well-developed preventive medicine program, and they are very aggressive with treatment of very active cases of TB. So really, we do not have almost, known patients with active tuberculosis from Cuba. And as you know, we have quite a few immigrants from that country as well. Primary multi-drug resistant tuberculosis, what's the definition? Definitely on your boards. Definition is resistance to what? INH and rifampin, right? Clear, straightforward definition. What's the definition of extremely drug-resistant tuberculosis? Resistance to what? All the first-line drugs, which is INH, rifampin, pyrazinamide, and tabutol. Second-class medications, fluoroquinolones, and aminoglycosides. So as you can imagine, quite difficult to treat. By the way, what is the cost of treatment of active TB? Regular sensitive TB on average. This is all covered regardless of patient's insurance or their status. Tuberculosis treatment is free. Any guesses? It's about $60,000. If it's multi-drug resistant, which means only the 2 medications, first-line medications resistance, it's about $250,000. If extremely drug resistant, you can imagine it's in the millions. I'm proud to say we are one state which has successfully treated extremely drug-resistant tuberculosis case, which is 5 years out of treatment and still doing well. Recovered completely. Patient was on a couple of years of multiple IV medications for the treatment. The problem with extremely drug-resistant tuberculosis, it is treatable, but in majority of cases it's diagnosed post-mortem. Therefore, as you can imagine, we don't have the ability, to, if you don't diagnose the patients on time, to treat them appropriately on time. So how do we diagnose TB? We all know about the PPD test, which is over 100 years old. Did you guys know that? Do you know how PPD test come to life? How it was discovered? It's actually a failed vaccine. At the same time where tuberculosis test came to light, they were working on the smallpox vaccine, and they noticed that the maids which were milking the cows and got monkeypox were immune to smallpox. So they thought the same thing may work for tuberculosis. So they inoculated partial AFB bacilli, hoping that this will work. Obviously, it didn't. But they noticed that the patients who were inoculated with the vaccine and had this horrible reaction to the vaccine later on came down with tuberculosis. So by a total accident, this failed vaccine for tuberculosis became a screening test for TB. What is the sensitivity or specificity of PPD? Any guesses? Meaning what percentage of the time it gives you the wrong result? It's about 20% of the time. So 20% of the time it's positive when it should be negative. 20% of the time it's negative when it should be positive. So it's not a very exact test. Therefore, we should not be screening everybody because of the high rate of false positivity and false negativity. So as healthcare providers, we come into the category of 10 millimeters. Remember, it's the measurement of the induration, not the erythema. So it's the raised area that we measure. For someone which is close contact to somebody with TB, who has old TB lesion or is HIV positive, 5 millimeters alone is enough to cause it positive. The question always comes up about BCG vaccine, right? Many patients or healthcare providers who have been vaccinated against tuberculosis, they have the higher risk of having a positive PPD, but the risk is only lasts for about 5 to 6 years. After that, the PPD should revert to negative after the BCG vaccine. So if someone is in their 20s or 30s and they had the vaccine as a baby, their positive PPD should not be coming from their BCG vaccine. Also, reaction of 15 millimeters or above, it's almost always tuberculosis. No other mycobacterium will give you such a pronounced reaction. So if you see any reaction of 15 millimeters or above, it's almost always TB. How come we don't give the BCG vaccine in this country? Absolutely, excellent point. So BCG vaccine is active against only neurological tuberculosis. It does not prevent pulmonary TB. Therefore, in this country, majority of our cases are pulmonary. So we don't have enough cases of neurological TB to warrant vaccination for everybody. But it's a very effective vaccine. Unfortunately, it only protects from neurological TB, does not protect from pulmonary TB. Our interferon-gamma release assays has partially replaced the PPD. It is not a 100% test because in addition to picking up Mycobacterium tuberculosis, it picks up other mycobacteria, which means this test will be positive with any of the mycobacteria which comprise the Mycobacterium tuberculosis complex. That includes, for example, Mycobacterium africanum, Mycobacterium kansei. So you would wonder, well, what's the use of this test if it picks up other mycobacteria? One advantage over PPD is that it does not pick up Mycobacterium bovis, and this is the mycobacterium which is included in the BCG vaccine. So someone, especially it's very useful, someone who's claiming that their positive PPD is coming from their BCG vaccine, that test would be positive. It was true exposure to TB. It would be negative if the positive PPD was coming from BCG vaccine. So it's especially useful sometimes, especially with, I find it useful to convince physicians who have positive PPDs that they truly really need therapy regardless of their BCG vaccination history in the past. Shortfalls of the test, again, picks up other mycobacteria. It needs to be processed within 8 to 16 hours. Pros, you don't need the patient to come back in 48, 72 hours, especially in outpatient setting for the reading of a PPD. If patient is immunocompromised or immunosuppressed, you can still get this indeterminate result. So based on the clinical picture, you need to decide if the indeterminate result is the positive indeterminate result or a negative indeterminate result. And we'll talk about it in just a minute. So what happens when you inhale tuberculosis? First of all, within the first 6 to 12 weeks, you have, believe it or not, just to get a positive PPD, you get a disseminated disease. For 6 to 12 weeks, tuberculosis just circulates through every single system of your body. And you have no symptoms at that point at all. That would explain why some people have this isolated tuberculosis of the eye, tuberculosis of the ovaries, tuberculosis of the knee, while there is nothing infectious present in their lungs. And depending on your own immune system, the tuberculosis may become latent, just go to sleep in your lymphoid tissue, or it would settle in your lungs, or especially if you are HIV positive, 60% of cases will become extrapulmonary. Do you guys know what is the number one place where tuberculosis settles in HIV positive patients, regardless of their CD4 count? Lymph nodes. 60% of the time, especially in lymph nodes in HIV positive patients. So extrapulmonary TB number one in HIV positive patients. So after conversion of your PPD from negative to positive, or the IGRA test becoming positive, your risk of progression from sleeping latent TB to active TB is about 5 to 10% within the first 2 years. Therefore, we recommend treatment the first 2 years after conversion. In HIV positive patients, the risk is 10% every single year. Therefore, regardless of their time, of the time of their conversion, we recommend treatment for HIV positive patients, no matter what. Because our patients live now more than 10 years, so if the risk is cumulative, within 10 years, they have a 100% chance of latent TB to become active. And as you can see, these are some conditions that I would like you to know, which increase the probability of the latent tuberculosis to progress to active TB. So obviously we mentioned infection with HIV, chest x-ray findings suggestive of previous, partially or untreated TB, substance abuse, recent TB infection, prolonged therapy with either corticosteroids, immunosuppressive therapy, such as prednisone, of course, the TNF-alpha antagonists, also patients with organ transplant, silicosis, diabetes, end-stage renal disease on dialysis, cancer, intestinal conditions such as Crohn's, and low body weight. These are all independent risk factors for progression. So being 10% below your ideal body weight is independent risk factors for transition from latent to active TB. So what is the treatment for latent tuberculosis? Something that I do need you to know for your exams. Recommended treatment, isoniazid daily for 9 months. Self-administered therapy. There is a new regimen that I need you to be aware of weekly INH with rifampicin combination. It's only 12 doses, but it has to be directly observed therapy. So it has to be, if you are administering to the patient, they have to come in once a week to your office, for someone from your staff physically watch them swallow the pills, or in the health department setting, someone either meet us at the office or go to the patient's home to watch them physically take the pills. Because of the high drug-to-drug interactions with heart therapy, this regimen is not recommended for HIV patients on HIV treatment. So the patients who are off therapy can still get it, but if they are on heart, the INH daily for 9 months is recommended. There's also INH twice a week for 9 months, but it has to be directly observed therapy. If patients have problems with INH, they are unable to take it, the second line treatment is rifampicin. It's daily for 4 months. It's not recommended as the first line because of the side effects. Which one out of those two is most toxic on the liver? Isoniazid, right? It's not the rifampicin, it's the isoniazid. So what is the cardinal symptom of TB? That if you have that symptom, you know you have tuberculosis? It's weight loss. Actually, it's a trick question, because as you can see, there is nothing specific about tuberculosis. I mean, we've all have felt this way one time or another, right? After exams or after international travel. And that's what makes tuberculosis so deadly. Unlike, let's say, flu, which you know exactly when you get it. You know, you'll be sitting in traffic at a red light at 2 p.m. and you instantly get sick, and you know you are getting sick. You know it's the flu. With tuberculosis, is so insidious that sometimes people walk around with weeks, months to years before they are diagnosed. Because if they get cough and a little bit of a pneumonia, what is the number one drug they probably will get outpatient? Quinolones, right? They may get the Z-Pak, but many times they get levofloxacin. And what is levofloxacin? It's a second line treatment for TB. So they will get better because it's a partial monotherapy treatment for TB, and then they get worse. They will get better when they get worse. So sometimes I see patients which have gotten, they had 5 episodes of pneumonia. Yes, you have to think about immunodeficiencies, but also think TB. And what happens when they get treated with fluoroquinolones? Their smears and their cultures are sterile. So it's almost impossible to that point without very invasive means to diagnose tuberculosis, because they probably got enough of antibiotic to sterilize the sputums. So how many AFB bacilli do you need for the smears to be positive? About 10,000. So a lot. And you only need about 100 of them to get sick. So think about it. Because tuberculosis is not very infectious, it only infects about 30% of its environment on average. We can get away with this continuing isolation when, technically speaking, there could be a 9,900 bacilli still floating in a patient's room. So sometimes you may see me still, even if the AFB smears are negative and we have high index of suspicion, we still may wear a mask until we put the patient on therapy. Even one dose of INH, believe it or not, can sterilize the sputums up to 90%. So it's pretty safe if the patient is on, has gotten at least one dose of the anti-TB therapy, that they are able to be without isolation. For patients with documented AFB positive smears, we need to have them on treatment. This is a question which often comes up in a hospital setting. Patient needs to be on treatment for minimum of 2 weeks to be deemed safe for them to re-enter the society, and ideally 2 definitions should be met. They should be AFB smears negative, at least for 3 consecutive smears. So 2 criteria need to be met for them to be able to go back to work: 2 weeks on treatment, and minimum 3 negative smears, consecutive negative smears for them to. Consecutive, meaning if you have negative, positive, negative, positive, it has to be negative, negative, negative. Whenever you are able to reach it. Because sometimes they are on 2 weeks of treatment, but it takes 3 weeks for us to get 3 negative smears in a row. So they would be on isolation for 3 weeks to meet the second criteria for them to return to work. So we usually, the first month, we obtain sputums daily. So whenever you reach, it could be 2.5 weeks, could be 4 weeks, whenever you get 3 negative sputums, regardless of the amount of time that you are able to discharge them into community. Yes? What happens when they don't produce the sputum? We try. In an inpatient setting, we have respiratory to induce. In an outpatient setting, we bring them to the clinic. We have actually special induction suite where you can actually induce the sputum. You try your best. If not, you have at least documentation of 1. If they are not producing sputum, chances are they are not very infectious to begin with. So you go by the definition of minimum of 2 weeks of treatment.
How about gastric aspirates?
Gastric aspirates are mainly used in children because it's very hard to obtain sputums from children. Usually as soon as they cough something up, they swallow it. That's why the gastric aspirates are very useful. But in adults, I think sputums are still the standard of. If you can get sputum, absolutely. Harder to get a gastric aspirate in an outpatient setting because you would need a GI suite for that. But in a hospital setting, absolutely. Especially someone who is intubated. If we cannot get suction, I have used gastric aspirates as well. But remember, sometimes they could be also destroyed. You have to have a fresh sputum because the tuberculi are destroyed by the gastric acid, like with any other mycobacteria. Okay. So why is tuberculosis in upper lobes? More air and less lymphatic. So actually, when we first get tuberculosis, it's before we become symptomatic. If we have a good immune system, tuberculosis will be in your entire lung. Only when your body is unable to clear it, that's when you become symptomatic. So many patients, 50% of patients, will have tuberculosis, will get better without knowing it, and never know they had it and get better. So that's why sometimes we have these incidental findings of granulomas on chest x-rays, and we'll ask patients, have you ever had tuberculosis? And they will say, no, never had it, never been treated. And granulomas are actually the old cavities, shrunken cavities, but the body was able to get rid of itself. So majority of the patients, they will get better by themselves. In those where they don't have a strong enough system, the tuberculosis will be cleaned up from the lower and the middle lobes, and in the upper lobes are the areas of the poorest lymphatic drainage. And that's why if the body cannot reach those areas, it will wall it off into cavities. And what are cavities? They are abscesses, right? Their body's way of walling off the infection, and will try to shrink the cavity as much as it can. But at that point, if the immune system is not strong enough, the patient would become symptomatic. In HIV positive patients, you will see that the TB will not have this classic upper lobe cavities. They may have right middle lobe, right lower lobe infiltrates, because they will become symptomatic before the cavity formation happens. So in earlier stages of tuberculosis. Okay? Any questions? So TB therapy, one of the favorite board topics. So ideally, if you are in an area which has 4% or more of resistance, and Hillsborough County is one of those areas, you would have to start the patient on 4 drugs: isoniazid, rifampin, pyrazinamide, and ethambutol. After 8 weeks of treatment, hopefully you will have back your cultures, because that's how long it takes for the cultures to grow. And based on the sensitivities, you will be able to discontinue the pyrazinamide and ethambutol, and for 4 months continue with just INH rifampin, and the whole treatment lasts 6 months, and the patient is cured. How often does it happen in real life? Not very often. Any examples you can think of why the treatment may be prolonged? Drug interactions, right? Toxicities. Patient gets hepatitis, elevated liver function tests. You have to hold the therapy. The treatment gets prolonged. If you miss more than 2 weeks during the first 2 months of treatment, you have to start all over again. So let's say the patient got 6 weeks of therapy, but they missed the last 2 weeks of treatment for whatever reason. None of that treatment counts, and you have to start all over again. Comorbid conditions, if a patient is using drugs, if the patient is alcoholic, they may be compliant with the therapy, but remember the medications will be competing in the liver for metabolism. So again, the therapy is not going to be effective. If the patient's smears and cultures are positive past 2 months, you have to continue treatment minimum 4 months post-culture conversion. If the patient cannot tolerate rifampin, favorite board question, the treatment is automatically prolonged from 6 months to 18 months. If the patient cannot tolerate pyrazinamide, what's the #1 side effect of pyrazinamide? Yes, elevated uric acid, gout. The treatment automatically is prolonged from 6 months to 9 months. What is the #1 side effect of ethambutol? Ocular. What is the ocular? Exactly, color blindness. So inability to discriminate between red and green. Okay. And rifampin and INH side effects, peripheral neuropathy with the INH, that's why we give the B6. And with rifampin and INH, both rashes and liver toxicities. There are main things that I need you to remember. So if the patient is pan-sensitive, we are able to DC the ethambutol and PZA or streptomycin after the first 2 months of treatment, and continue with INH and rifampin. For this to happen, they have to convert their cultures to negative within the first 2 months of treatment. Relatively new guidelines. Before, we used to have a 9-month treatment for HIV positive patients. At this time, the treatment for HIV positive and HIV negative patients is the same. 6 months. It's counterintuitive because they are immunosuppressed, so you want to do more and longer, but the treatment is identical. You can use twice-a-week therapy after the initial 2 weeks of treatment. If the patient is HIV negative, because remember it's still DOT, the doses are going to be higher, but the patient only will be swallowing the pills twice a week. You can use 3 times a week therapy in HIV patients, and I wanted to teach you why. If the CD4 count is less than 100, or the patient is on Coumadin, or the patient is on anti-seizure medication, the therapy has to be daily for the entire length of treatment. If the CD4 count is above 100, you can, after the first 2 months of treatment, use 3 times a week therapy, because the patient will be on rifampicin or rifabutin and INH. Why not rifampicin? Because of all the drug interactions with protease inhibitors and other heart therapy medications. Because of the half-life of rifabutin, which is very long, about 20 some hours, INH half-life is only 6 hours. So if you gave only twice a week therapy, the patient will have functional monotherapy. So therefore, in HIV positive patients of rifampicin or rifabutin, the frequency has to be 3 times a week, so the INH is not alone. Okay? So that's something that may come up on the ID boards. Why the 3 times a week therapy, when to use daily therapy on patients, when to switch. Okay? Any questions? Resistance, INH, why the highest? Because that's the drug used for LTBI, so this is a drug used the most often in the community. Streptomycin, why? Because aminoglycosides are used for other infections, so again more used in the community, then followed by rifampicin, ethambutol. For all 4 drugs, about 0.2% at this time. Clinical significance, common sense, the more drug-resistant tuberculosis it is, the harder it is to treat. The longer it's going to take to treat, the more medications you're going to need for treating. And again, as I mentioned before, 50% chance of cure without treatment, meaning half of the patients with tuberculosis will get better by themselves without treatment, but they have to have really good immune system and none of the comorbid conditions that we mentioned before. Multi-drug resistant tuberculosis, really immunosuppression or HIV is not a risk factor. There is a new data coming out that it possibly could be if the HIV and the opportunistic infections associated with HIV are cause of decreased drug absorption. That could cause resistance if you have lesser drug levels, but per se, HIV alone or immunosuppression alone is not a risk for multi-drug resistance. What is? Poor adherence, poor prescription practices, and poor drug quality. So be careful for many patients who were treated for tuberculosis abroad, and even if they have the documentation of completion of treatment, in many places, about 20% of the medications are counterfeited, so they are not active. So even the patient completed therapy, they may not have because of the medications that they have received. So I have quite a few cases in the past few years where the patients had documented treatment, yet they have a reactivation of incompletely treated tuberculosis. Okay? So I do have to talk about TB and HIV because of the special relationship that TB has with HIV. These are the only 2 infections that independently of each other accelerate the progression of each other. So what do I mean by that? If someone has latent tuberculosis and they require HIV, HIV will wake up their sleeping tuberculosis and make it replicate, and vice versa. If someone is well controlled on their HIV therapy, has high CD4 count, undetectable viral load, and they acquire TB. And remember, tuberculosis is one of a very few opportunistic infections that you can get regardless of your CD4 count. Because remember, you acquire opportunistic infections with CD4 count less than 200. With tuberculosis, your CD4 count could be 1,000. You are still at a higher risk of acquiring it. So with patients well controlled, if they acquire tuberculosis, tuberculosis will wake up the well-controlled HIV and make it replicate. We don't see this with any other infectious diseases. So TB and HIV affect the same populations, about HIV-infected, recently infected, persons with other medical conditions that we mentioned, malnourished who inject IV drug uses, also with history of inadequately treated TB infections in the past. Did you guys know that TB is the #1 killer of HIV positive patients of all causes? And it's #2 killer from infectious causes of anyone worldwide. What's the #1? That's a board question as well. What's the #1 cause of death worldwide from infectious causes? Malaria. Malaria #1, tuberculosis #2 from infectious causes, cause of death worldwide. #1 cause of death of TB patients worldwide because of this specific interaction. So as you know, we have to be very aggressive of treatment of TB in HIV positive patients. Epidemiology, 2 billion individuals infected worldwide. 1/3 of them are co-infected with tuberculosis. Very high numbers in sub-Saharan Africa. About 20% co-infected patients in Southeast Asia. Again, leading cause of death amongst HIV-infected patients, and #2 for worldwide infections. As you can see, TB and HIV go hand in hand. Nothing has changed between 1993 to 2012. The better treatments we have for HIV, tuberculosis numbers decrease. Pathogenesis, we already mentioned that for HIV positive patient, you have an ongoing risk of TB becoming active, 10% per year. 2 mechanisms, either reactivation or reinfection. And of course, we have to remember about reconstitution. And there are well-described pathways, but at least if you guys see those on your exams, you are able to recognize them. How tuberculosis induces the progression of HIV by inducing the replication of HIV cells of the monocyte lineage in the acutely infected macrophages, and how it activates transcriptionally latent HIV in alveolar macrophages and monocytes and recruits them to the site of TB infection. And there are actually well-described pathways how tuberculosis induces the TNF-alpha and accelerates HIV replication through either the nuclear factor kappa beta, p38 MAP kinase, high levels of a non-inhibitory chemokinase, MCP1, and low levels of inhibitory beta chemokinase of the MIP1 beta and the RANTES. Please be aware if you see those that they are part of that deadly pathway. Treatment for latent TB in HIV, INH for 9 months. In the new regimen that I mentioned of the INH and rifampicin for 12 doses with directly observed therapy. Again, not recommended for patients on heart. For patients with co-infections, treatment of TB should follow the same principle, except remember, if their CD4 count is less than 200, especially less than 100, their PPD may be negative, their IGRA or blood test may be negative too. So in patients with AIDS, low CD4 counts of, let's say, CD4 count of 5, your chest X-ray will be negative, your PPD or IGRA will be negative. The patient will not have leukocytosis. They may not even have night sweats or a cough. Sometimes the only presenting symptom of tuberculosis in those patients is weight loss, which could be easily attributed to AIDS wasting syndrome. So there's really not a one objective test that you can order that will be positive. So you have to have a really high index of suspicion and be able to convince the patient to start TB therapy at least for 2 months and see if they improve. Once you start their TB therapy and the patient starts feeling better, that's how you know you are treating tuberculosis. And it's very difficult because many of those patients, you will ask them if they feel bad, and they say no. Do they have lower energy? No, because this disease has been so progressive, they have gotten used to their lower level of functioning. Only when you start the TB therapy and we start feeling better, that's when you know you are dealing with tuberculosis. Okay? And of course, we still have the same problem with immune reconstitution syndrome, both with HIV and TB. So if you have somebody with both TB and HIV, which treatment do you start first? TB or HIV? TB. TB. You start TB first. So if they are already on HIV therapy, you just add the TB treatment on top of their HIV therapy. But if they are diagnosing, sometimes we diagnose them with both at the same time in a hospital. You start the TB therapy first, and that's definitely on your boards, followed by the HIV therapy. How long do you wait before starting HIV therapy? Minimum 2 weeks. Okay? If their CD4 count is higher, you can wait longer. Okay, so if the CD4 count is, more than 50, within 2 to 4 weeks. If it's above 50, sometimes you can wait. If the CD4 count is above 500, you may be able to finish the entire TB therapy before starting HIV therapy. So it's all going to depend on the patient's immune system. Why is it important to space it out minimum 2 weeks? It's because of the immune reconstitution syndrome. Because remember, you will be reconstituting from both diseases. So if you started the treatment at the same time, first of all, imagine the side effects from both sets of medications at the same time. Number two, they will have the iris superimposed on each other. So the inflammatory reaction itself could kill the patient. And number three, they will be getting the TB therapy as DOT, which means they will be getting it. What are the chances that they will take another regimen, even if it's only once a day, one pill, on their own, if it's going to give them more side effects? So because of several reasons, we like to start the TB therapy first, and usually most of the side effects they will experience from the medications will go away after 2 weeks of treatment. That's why another reason why the magic 2 weeks, that we want to get their body used to the TB therapy before we introduce another regimen for HIV therapy. Okay? Any questions? For pregnant women, as you know, start HIV therapy as early as possible, especially so these are the women you're going to be doing minimum of 2 weeks of waiting, regardless of their CD4 count after you start their TB therapy. Especially watch out for the inflammatory response, because that may be augmented, and again, we will be definitely consulted, will be on the case of those patients. For documented MDR and XDR TB, again, this is the time you would only wait 2 to 4 weeks maximum, because with XDR, MDR, you want to make sure that the HIV is under control as soon as possible, because we are in for a long haul. These patients are going to be treated minimum 18 months, 24 months, or longer. Okay, so it's minimum 2 years of treatment. Our patients, as I mentioned again, who are already on HIV therapy, we just safely add the TB therapy on top. Always remember to switch the rifampin to rifabutin because of the lesser side effects, especially with the protease inhibitors. Few things that I need you to know. Possible interactions that they like to ask you on the boards about for protease inhibitors and non-nucleoside reverse transcriptase inhibitors. Rifampin may be used only with efavirenz, nevirapine, or full dose ritonavir. May not be used with ritonavir boosted protease inhibitors. Rifabutin is recommended with nevirapine and other PIs, but you always have to dose adjust. And remember, for example, for Maraviroc, you need to increase the dose when it's used with rifampin or rifabutin, and raltegravir also requires dosage increase when used with rifampin or rifabutin. So it's not always the TB. Sometimes the TB therapy has to be adjusted. Sometimes the HIV therapy has to be adjusted. But these are the few medications that they would like you to know on top of your head. Maybe not necessarily the amount of adjustment, but the fact that you need to either increase it or decrease it. So they will probably not ask you the exact dosages, but they do expect you to know which one you have to increase, which one you have to decrease. Okay? And again, iris, most common, as I mentioned, after IRT initiation. Especially in patients with low CD4 counts, less than 50, less than 30 days of starting of TB therapy, very infrequently associated with mortality. Most of those patients, we're going to continue the treatment for TB and HIV, non-steroidals, and for severe cases, steroids and admission to the hospital. And something that also I need you to to know about TB therapy, usually when a patient gets a reaction, let's say a rash from an antibiotic, and it's severe rash, severe reaction, we would label the patient as having a drug allergy, and we would not reintroduce that antibiotic again. That's different about TB therapy. Let's say we give them RIPE, all 4 drugs, and they get a rash. We stop the therapy until the rash resolves, and then we will reintroduce the therapy again. This is the only time with a rash and with an allergy, if you will, you would reintroduce the therapy again. But we would not start all 4 drugs. We would restart it 1 drug at a time. Usually you will start with a drug which is the most important one. So we will start with rifampin. We wait 2 and 3 days. You're not going to develop resistance with that monotherapy, because remember, tuberculosis only multiplies once every 24 hours. Unlike E. coli, which is every 20 minutes. So waiting a day or 2 is not going to cause significant resistance. So you would start with rifampin, you would wait 2 and 3 days, see if the patient has any side effects. Not only you decrease the chances of the reaction, but also you can isolate which drug caused it. Then probably followed by INH, wait 2 and 3 days, followed by PZA, usually ethambutol is added last. So with that sequence, 80% of patients will not have the repeat rash and the repeat reaction when you reintroduce the drugs 1 by 1. And then by the end of a week, you are back on full RIPE treatment with a patient. Sometimes we have to do it 2 or 3 times, reintroducing the medications, because each drug separately gives you no reaction. When you reach the RIPE full treatment, they get the reaction again, you stop. So we start, before we give up any drugs because of the consequences in the length of treatment, we like to do it maybe 2 or 3 times, which you would never do with antibiotics and rashes. And sometimes on a 3rd or 4th try, the patient has no reaction and can continue with the treatment. So that's one different caveat about TB therapy, which you're not going to see with other mycobacteria or other bacteria. Remember also pyrazinamide, this is the only one that is used for TB therapy. So if you see any questions on the boards for other mycobacteria, choices of treatment, if PZA is included, that's wrong, because PZA is only used for TB. And another thing, PZA is not used in pregnancy. So remember PZA for pregnancy. If some patients are, on treatment and they get pregnant on treatment, do not be worried. Many patients are successfully pregnant treated with PZA-containing regimens in Europe without any side effects. In the United States, we don't have enough studies to warrant safe recommendations. So usually when we know somebody is becoming pregnant, planning on being pregnant, we hold the PZA, and remember their treatment automatically will be prolonged to 9 months. Okay? So a few questions. If you have HIV and TB, do you need to add higher number of drugs? Yes or no? No. Remember, treatment for TB in HIV positive patients is the same as for HIV negative patients. Do you need to prolong duration of therapy? No, treatment is exactly the same, minimum 6 months. Also, I wanted to mention in patients which let's say they've gotten the outpatient Levaquins and their smears and cultures are negative and you don't have anything to go by, how long do you treat the patient? Right. If you don't have cultures, you don't have sensitivities to go by, what would be your treatment regimen? That's something that is also on your boards. You will have to use 4 drugs, right? You cannot drop anything because you don't have sensitivities, but the treatment can be shortened to 4 months. So patients where the cultures are negative, you don't have sensitivities, or the lab lost the specimen, whatever the occurrence may be, if you do not have reliable sensitivities, you can finish the treatment within 4 months. So you can treat for 4 drugs, with 4 drugs for 4 months. But if you have the sensitivities, usually in many cases, you are able to drop 2 drugs and makes it much more palatable for the patient to continue treatment. Can antiretroviral therapy can be used concomitantly with anti-TB therapy? Yep. Just remember, don't start both at the same time. TB always treated first. minimum 2 weeks between treatment. The higher the CD4 count, the longer you can wait. With CD4 counts above 500, you can sometimes finish even the induction phase with the first 8 weeks of treatment before adding HIV therapy. Any increased incidence of side effects in HIV-positive patients? No. Trick question. They're still going to have the gout, they're still going to have the vision problems, so the side effects, except the drug interactions, possible drug interactions with heart therapy, the side effects from TB therapy will be the same. There is any increased incidence of MDR TB in HIV-positive patients? No, because MDR is not associated with the host immunosuppression, is associated with the intermittent therapy, incomplete treatments from the past, and substandard drugs the patient might have received. Should latent tuberculosis be treated in HIV-positive patients? Always, regardless of the time of conversion. While for HIV-negative, remember, highest risk and recommended treatment is within the first 2 years post-conversion, either the IGRA or PPD. Any questions?